I'm going to discuss a case about the role of genetic testing in kidney transplantation, in particular, the role of testing the living donor. So the case I'm going to present today is of a 38-year-old white Hispanic female who had renal failure secondary to collapsing glomerulopathy. She underwent a living donor transplant in 2007 that was complicated by early thrombosis, and then had a second deceased donor transplant in May 2009. She was doing well until recent hospitalization in March of 2020, and a biopsy at that time showed transplant glomerulopathy. And as her GFR met criteria, she was referred for a retransplant evaluation. Her additional medical history was, in addition to the deceased donor transplant in 2009, was a BAF2A cellular rejection 18 years after that first transplant. And the biopsy in March of 2020, in addition to showing transplant glomerulopathy, also showed a chronic thrombotic angiopathy with suggestion of either drug-induced injury or a procoagulant state. Her additional medical history included hypertension, asthma, anemia, chronic diarrhea, and multiple joint pains in her hands and feet, as well as anxiety. Because of the concern for recurrent thrombotic microangiopathy, we decided to do genetic testing on her. And we chose a renal genetic panel that tests for multiple genes associated with renal disease, as opposed to testing for a single entity such as thrombotic microangiopathy. The test actually came back negative for any condition related to a procoagulant state, but she did turn out to have the high-risk genotype for ApoL1. She had a G1, G2 variant. Her donor was her sister, and she had been cleared for donation. So the question is, should the sister also have genetic testing? The patient has a high-risk variant for ApoL1, and it's possible that the sister may also have a high-risk variant. And so the question is, what is the data that would support testing for the donor? This is a controversial area. There's no clear policy with regards to this, but what I'd like to present to you is some of the data that we do know about genetic testing in living donors. As you've already heard from Dr. Pollock, the ApoL1 high-risk variant is associated with an increased risk of kidney disease. It usually doesn't cause kidney disease even when you have the high-risk variants, but in the addition to second factors such as FSGS or HIV-associated nephropathy, there's a high risk of kidney failure. We know that transplant recipients who have high-risk variants in the donor kidneys have an increased risk of kidney failure after transplantation. We don't see the same associated risk if the recipient has a high-risk ApoL1 variant, is only associated with the donor kidney, and it is thought that this means that the protein is being expressed within the kidney itself. While the majority of patients who have a high-risk variant for ApoL1 do not develop kidney disease, we also know that people who already have chronic kidney disease progress faster to end-stage kidney disease if they do have a high-risk variant. We also know that the risk of kidney failure amongst African-American donors is higher than that amongst Hispanic or white donors. It is thought that a lot of this risk is associated with the high-risk ApoL1 variant, although this hasn't been conclusively shown. One small study did show that patients who were donors who had high-risk ApoL1 variants had a lower GFR at the time of donation and progressed faster to chronic kidney disease. And in fact, in this study, 2 patients who had the high-risk variant ended up with having end-stage renal disease. So there is a concern that the high-risk variant for ApoL1 in kidney donors is associated with increased risk of end-stage kidney disease. When we do think about testing living donors for the high-risk ApoL1 genotype, one of the things that is rarely discussed is what the community itself feels is appropriate. This is a paper that took the opinion of the African American community about whether testing for the APOL1 high-risk variant should be done in both recipients and donors. And as you can see from this paper, it was felt in this discussion that it's very appropriate to do APOL1 high-risk variant testing in all cadaveric kidneys. But it was also felt very strongly that this test should be offered to all potential living donors. In fact, we know that the number of people who've donated do have a risk of developing kidney disease. This is the data from the UNIS registry that shows the number of people who are on the transplant list because they've been previous donors. And as you can see, this is around 50 patients per year. So if there's anything that we can do to reduce this risk, we should really be thinking about doing that. So in this case, we did decide to test the sister, and it turned out that she did have a high-risk APOL1 genotype. She had G1, G2, just like the recipient. And after a significant amount of discussion, she decided not to donate. Her boyfriend was evaluated and cleared as a donor, and they're now both in the paired exchange program as he was ABO incompatible with her.